Great. So this is 10 a.m. prompt. Hello, everybody. My name is Adeola Alli. I'm the CEO and co-founder of One Health. One Health is an online pharmacy and healthcare platform providing access to quality medicines and healthcare solutions. At One Health, what we're building is a digital trust infrastructure where people get access to vetted medicines and healthcare solutions. And the subject of today really is about antimicrobials, right? So celebrated every 18th to 24th of November each year, the World Antimicrobial Awareness aims to increase awareness of global antimicrobial resistance and to encourage best practices amongst general public, health workers, farmers, and animal health professionals and policymakers to avoid the further emergence and spread of drug-resistant infections. In May 2015, a global action plan was enacted to tackle AMR, that's antimicrobial resistance, and was endorsed by the World Health Organization, supported by Food and Agriculture Organization of the United Nations, and also the World Organization for Animal Health. So the first objective of the plan was to improve awareness and understanding of antimicrobial resistance through effective communication, education, and training. And to help achieve this objective, FAO, OIE, and World Health Organization, collectively known as the tripartite, have jointly supported WAAW, I guess, and World Antimicrobial Awareness Week, which is what we're celebrating since 2015. So together with the general public, students and policymakers and professionals from around the world and various sectors around the world, we are really celebrating this week to bring awareness, we at One Health, to bring in awareness, and your support. I mean, this whole, I would say, cohort of healthcare professionals, support is really essential in making the campaign a success. So today, we have a pleasure of bringing on to this webinar series that we're going to be having every quarter, and touching upon different subjects in that time frame. Our amazing speakers to talk to us about the issues that we're currently facing with antimicrobial resistance. And the topic of today is the age where drugs don't work. So we're going to welcome onto stage, you already see their faces. Thank you so much for joining already. So we're going to welcome Dr. Orunmuyi. Dr. Orunmuyi is a consultant nuclear medicine physician at the University College Hospital Ibadan and a member of the faculty at the College of Medicine, University of Ibadan. He's passionate about nuclear medicine, and is the convener of the PET in Nigeria PIN project. He's also my very good friend, advisor, my docky. Hi.
Hello.
Doc, if you just
Thanks for having me. Good morning, and hello to everyone.
Thank you, Doc. Great to have you. I'm looking forward to hearing all you have to say about this matter. And to my second panelist, we have Ndubuisi Ezumezu. He's a pharmacist with advanced degree in both public health and clinical pharmacy with over 10 years of experience that encompasses infectious and non-communicable diseases, research, quantitative data techniques, pharmacotherapy, quality assurance, and control and capacity building. So happy to have you here, Pharm. We can't wait to hear from you. Thanks for joining.
Thank you. Thank you for having me.
Awesome. Okay, I think we have one more panelist. I'm not sure, but I'll be bringing them on once I see the video on. But I'll just go right to it. So this is an open question, and like anyone can just take it. So what do we understand in practice right now as antimicrobial resistance? What do we understand it to be, and how do we see it in practice? So maybe I'll go with Dr. Orunmuyi first.
I was hoping the pharmacist to go first.
Right.
Well, so
okay.
Antimicrobial resistance. First, let's start with what's an antimicrobial.
Yeah.
In the broad sense, it's an antibiotic or any drug that works against bacteria and fungi and a couple of infectious diseases, infectious pathogens, but not viruses. So in the broad sense, antimicrobials are used in human medicine, in veterinary medicine, and in some forms of agricultural practice. So fishes, chickens, those who raise animals also use some of these antibiotics. So antimicrobial resistance is the process by which these pathogens become, I don't use the word resistant, but the drugs no longer work. The drugs that treat conditions caused by these pathogens no longer work because the pathogens have sort of evolved to evade the therapeutic effect of the drugs. So that's saying it in layman terms. Maybe the pharmacist can give us the Oxford Dictionary definition of.
Over to you, Pharm.
All right. Good morning, everybody. Once again, I'm not going to give any Oxford advanced learner stuff or anything. I think it would be good that we'll be as simplistic as possible. But thank you for the intro. So just like you said, what is microbial or rather antimicrobial resistance? It's simply put, I believe survival is an instinct that everybody has. At a cellular level, at a systemic level, nobody wants to die. So we throw drugs, we throw antibiotics, we throw arsenals at the microbes. And for one reason or the other, they develop their own strategies to prevent the objective of they being killed. They try their best to abort it. So when they are able to achieve defeating our purpose of administering our antibiotics through whatever means, I'll refer to that as antibacterial or rather antimicrobial resistance. Different factors bring it about, but I think we'll keep it there for now.
Okay, awesome. I'll just pause here to introduce one of our panelists, Dr. Pharm Temilola Olufohunsi. I hope I'm pronouncing it very well. If I'm not, my mom will not be happy. Yeah, she's the Director of Pharmacy at Lagos University Teaching Hospital, Idi-Araba, Lagos. Thank you so much. It's such a pleasure to have you here. I was so excited when I heard that you're going to be here. Thank you, ma'am, for joining.
Thank you so much for coming.
Great, awesome. Okay, so I guess my next question, and I was asking this question before Pharm Temilola joined, and Dr. Temilola joined. We were talking about, we're trying to define antimicrobial resistance. I think we have a good sense. So I'll go back to practice, right? In practice, how have we seen the effect? What do we see now? Because, you know, there is what we hear in profession, like, yeah, it's going to be resistant, but I'm like, kidney, like, how is it being resistant, really? I'm still taking my anti-malaria, nothing happened, I'm still taking, in reality, people don't understand that, and they're still continuing their behavior. So maybe you can give us some insight to what you see behind the scenes that's caused or prevented maybe treatment, successful treatment therapies due to antimicrobial resistance.
Well,
sorry.
Okay. Go ahead, ma'am.
No, please speak on. My device is acting up. I'm trying to listen to the question. No, I should change the device.
Okay, ma'am. I'm not sure if you got the question. Okay, so maybe Doc can continue and then.
Yes.
Okay, so you know, we also have to answer the question in context. So in Nigeria, as in most developing countries, the health systems that regulate the purchase and consumption of antimicrobials are lax. In addition, we have a unique healthcare system. I say unique because one, there's no health insurance. Less than about 5% of the population is insured, and over 70% of the population obtains healthcare by consulting with a local chemist or even buying drugs in a bus. So if you're in Lagos or most cities, it used to be commonplace to find people selling drugs inside a bus, and they sell all sorts of combinations. But even among the relatively higher social class or social status people, the experience is somebody has passed 2 or 3 loose stools, and by the time they come to see the health professional, they say they've taken flagyl, and they took 1 tablet a day and the stooling stopped. And immediately you know that flagyl once a day, one tablet does not stop stooling if it was the cause. But then you have several people self-medicating. So, you know, and the health space in Africa is probably going to be dynamic in the sense that we are recommending task shifting. So not everybody needs to be a doctor or a pharmacist. Not every health worker needs to be a doctor or a pharmacist, but some people, even laymen, can be trained to cater to common health problems. The downside of that is anybody can call themselves anything they want. And then, you know, there's all sorts of people are, you know, calling themselves different kind of doctors. So looking at that context, certified healthcare professionals and other people are prescribing antibiotics in inappropriate ways, one. Two, self-medication is also happening inappropriately. People are using all sorts of treatments for all sorts of ailments. And then if you look outside the medical space, going back to the concept of One Health that Adeola mentioned at the beginning, some people believe if you add tetracycline to your chicken feed, the chickens will not fall sick. I'm not a vet, and I wish we had a vet here, but again, all these antibiotics and drugs then find their way into the bacteria in the local or in the natural environment, and then also finds its way into the final finished products, which we consume as food. So all this is the reality here. And the effect in clinical practice, I would also let the pharmacists talk about it, is worse for elderly because the elderly have some the immune systems are not as strong. And then when they come down with diarrhea, you take a stool test and go to the lab and it comes back resistant to all the common drugs. And then now we have to use these very expensive drugs that some of the side effects could also be stooling. And in a 70, 80-year-old person, some of the side effects of the drugs are more pronounced. So for the elderly, the immunocompromised, as patients like patients who are receiving treatment for cancer or patients who are receiving treatment for HIV, and even COVID patients will be somewhat immunocompromised. When they come down with usual infections or typical infections, when you send their blood results for culture, it comes back resistant. And then we now have to scramble around looking for what antibiotics to use. So it's difficult to blame one person or one thing, but the effect we're seeing is more people who need these antibiotics cannot benefit from it when it gets to the time to treat them. So they stay longer in hospital. They spend more when they stay in hospital. They don't get well on time. And sometimes they develop more complications from antibiotic treatment.
So we're actually seeing this as a reality in Nigeria, that a lot of people are not, responsive to antimicrobials. That's very interesting. And I guess, so what are you then seeing as, I just asked a lot of follow-on questions because I just want to get clarity. So what have you then seen to have eventually worked? Is it usually the neurotherapies, or like how do you resolve those cases in those situations?
Fortunately, I practice in a tertiary hospital, so I have the complement of a microbiologist, actually two of them. And we also have an infectious disease specialist in UCH. So basically, I just ask them to come and see. And that sort of helps us not to experiment, try or, yeah. So they sort of find ways to do it. I don't know how they do it, but yeah, they help us a lot.
Maybe I'll then ask Dr. Olufohunsi, in your clinical practice as a pharmacist, how do you deal with patients that are not responding to the numerous antimicrobials, and how do you then start to eliminate, or what are you starting to advise people to do when everything doesn't seem to work? because honestly, in my opinion, I've always thought that I really question as to, because it seems like that the idea of you cannot just pop flagell has not really penetrated into the society, and it'll be very, very important to really, you know, showcase and really inform the public as to why this is very dangerous. Over to you, Ma.
Oh, thank you very much for having me this morning. In my, for the period of the experience I've had so far, there are so many misuse and overuse of antibiotics there. Outside, even in the clinical practice, in the hospitals, you see patients that have maybe cold or something that does not really need antibiotics. They demand for it from the physician to write for them. I know that with the knowledge or all the awareness about the resistance, the physicians too, they are working on it to be sure that I know that they'll tell them that you don't need it. But these people, what I discover is that they go out there because there are a lot of quacks. The patent medicine, the chemist, or whatever name they call them, that are ready to give. I was in a shop. It was a senior person, not a pharmacist. The person has a patent medicine store, and the patient walked in, and I saw her giving her was it Antimicrobials, maybe like 2 tablets or 2 capsules. I was like, why? Why did you do that? Don't do that. She said I should not spoil our market. In other words, a lot of people practicing out there, they don't really know what they are doing, especially those that are not licensed to do the to market or to sell drugs to patients, because they don't know the implication of what they are doing. So that is why we have a lot of resistance out there. Even those that know, once they feel better a little, after taking the maybe first day of the course of the antibiotics they are supposed to take, because they are relieved, the tendency is there for them to sort of forget or leave it or miss doses. So in such cases, we advise that, you know, that's why it is better to have the antibiotics that the dosage regimen is not such that the person has to take it like 3-4 times a day. If it is just the one that is BD 2 times a day, it's easier for them to comply with. So as much as possible, if there is any, one of the things that is also reasonable to do is not to just start from the antibiotics that are broad spectrum, because that's one of the things that we see in the practice. Because the patient is coming down with a particular thing, the physician may not have the patience of waiting to know the causative agent. They just start from one high antibiotic there, rather than going from the lower one. That means low, what do I call it now? That is not broad spectrum. So to treat the patient and send for to the lab to be sure of the one that particular pathogen will be sensitive to. So one of the things that we advise is that our clinicians or our prescribers should please try and not start from the broad spectrum antibiotic while prescribing for the patient, because those are the things that also contribute to the resistance. Because when you start from the highest one and start coming down, the patient is already exposed to that antibiotic. And when the time comes for such to be used, you discover that the patient no longer responds to it. And those are the problems we are facing out there. Apart from the general public, the way they misuse it, like the one I cited the other time, we have a lot of it there. Like the metronidazole, everyone that has diarrhea, you go for the first, maybe they just say take 2 tablets. By the time you take and the thing stop, that is the end of it. And when such is required at the end of the day, it's no longer useful. But we continue to educate and continue to give advice or our prescriber, because we all work together, and I believe that we will get there. I believe that it's a war that all of us must fight, and I believe that we must not get to the level where there will be no antibiotic or antimicrobial to use any of those problems, of those infections that may arise anytime, anywhere.
Okay, thank you so much for that contribution. So as a follow-up, I have this opinion piece that I read some time ago by a professor at the Brighton Sussex School in the UK, and they said that apparently complete the course that's been taught widely is actually wrong, and that there's new research that says that you don't have to finish your dosage. I don't know. Did you hear that? I don't know. Maybe I'll go to Pharm Ndubuisi because you're in the genetic sector. Have you heard of that before? Because when I bought that, I was like, oh, okay, maybe that apparently if you complete your dosage, when you start to feel better, you may actually get more resistant. Is that true? Or what, have you heard anything about that in practice? I'm curious.
Okay, thank you. Thank you for that question. To the best of my knowledge, I've not heard of that. Some of these things could be theoretical in nature, and probably they've not gotten substantial, widespread evidence. But the best I know is from the genetic perspective, which is still in this part of the world, still developing that area. It looks as we consider pharmacogenomics and precision medicine, trying to tailor the needs, the medication needs of individuals to medication. But to the best of my knowledge, not completing a course of antibiotics, it will do more harm than good, as at current knowledge. I've not gotten to know any study yet. Maybe you might want to share that with me of there being more risks of not completing the course of antibiotics. But that being said, it's now being known that there might be there are some medications that work better in people. There are some people who might benefit from the course, with respect to duration of an antibiotic or some other medication, as opposed to some other people that will need longer courses. And all these are due to genetic durations. But in general sense, not gotten to know about any situation where not completing an approved course of antibiotics will benefit the patient. I think those are still some things that will cause resistance when taking antibiotics.
Can I say something?
Yes, please.
Okay, I want to say that according to what he said, I've not heard about this, but I want to say that if a course, during the clinical trials of these drugs, the pharmacokinetics and all the rest, they would have performed all those things to be sure of the right dosage that will be in the system before that pathogen can be completely eradicated. So if there is anything contrary to that, I don't believe it is the right thing not to advise the patient not to complete his dose when the person feels relieved, because they think that those are the things that will even cause resistance, because it's like you have killed the pathogen halfway and it can come back and mutate and cause. And so I don't believe there is any benefit in not completing the course of the antibiotic.
Okay. Doc, do you have any other additional info about that before I move on to?
So I wish I could say the same, but unfortunately I'm with Adeola on this, that the first part of the evidence is first to ask that how did we know antibiotics should be used for 5 days, not 3 days, not 7 days, or not 10 days? And the early research, the evidence was just anecdotal. It wasn't really serious studies as such, but there have been imaging studies at the molecular level that sort of look at the viability of pathogens inside the body which is close to what I do as a nuclear medicine doctor. Basically, you can now label your drugs or even some parts of the organism with a radioactive substance, and then you can see in vivo, that's alive, how it works. And those studies show that indeed, most of the pathogens are undetected or undetectable within a few days of using the antibiotics. So I think that's where the information came out that maybe courses of antibiotics should be shorter. The bias for the study is one, what is the detection limit of the test? Are we saying the test can detect picomolar or even nanomolar pathogens? And then two, if the antibiotic has worked, what is the cause of the symptoms? So symptoms disappearing might not necessarily be because the antibiotics has worked, because some of these symptoms of disease, fever, and the rest are due to release of toxins, either when natural immune cells fight against the bacteria or even containing the shell or the outer casing of the bacteria. So I think the jury is still out on that. And for now, we still have to prescribe as we have always done. And patients must complete their dose, but maybe in the future things will change. So we just keep our fingers crossed and our minds very open.
Yeah, it's very, very important to reiterate that as long as we are not the researchers and we have not come out with an alternative dosage, we just stick to what we know. But I just wanted to put that out there because when we do, I have people ask me that, but they've told us that we don't need to finish it. So I'll split it, especially people that are traveling. They go like, oh, I have this dosage. I know it will last. If I take half of it, it will solve it. We don't have to finish it anyway. And this will solve that, and that will solve that. And I'm like, okay, so how do I mitigate that? Because they give me evidence of the research, like you're saying. So it's safe to say, complete your dosage. We have not found the formula, and they have not revised that. So you still just do as you are told for now until there's a full jury that comes out to say this is how we should be prescribing and take antimicrobials. So I just wanted to put that out there because I know a lot of people that have asked me that question, and it was important to discuss that. I don't know. I think Dr. Temilola wanted to say something, or maybe I just read the body language different.
Maybe what I wanted to say is that there's no compliance with any medicine. It's not an easy thing. So everybody will want, there's tendency not to finish whatever drug is given to anybody, especially the other drugs may be okay, but antimicrobials, like I used to tell patients, is not something you can compromise because it can develop resistance when next we need it. So I think we should still continue to let our patients know that we have no choice but to comply and do it and take the thing to the end.
All right. So are there alternatives? Go ahead, sorry.
Okay, yeah, just to add, just like the doctor said, until we get that is what compelling evidence, we should stick to status quo. Let me cite an example. That's compliance. So when I was still in infectious disease, HIV, we were seeing, we all know that the level of adherence or compliance that is needed for optimal efficacy of the antiviral as high as 99%. Right? So telling these patients at this point that there's evidence or there's some suggestions that you don't have to complete your course or etc. could be counterproductive at this stage. We're seeing cases of and bear in mind that we've not started doing genetic testing before commencing antiviral therapy this part of the world. Then you want to combine that with cases of developing cases of NDRT. Now we're talking about XDRT that is not going to be cured by most of our available regimen. So at this point, giving out that information, I think we still need to private education comes in to educate our clients that these studies are still underway. And fine, if it comes out that we have to eventually reduce the cost of the antibiotics or antivirals, well and good, that will profit everybody. But Myself, I don't like taking antibiotics like every 6 hours, all of that. So I think we need to sort of put our patients that let's just stick to this way when information is now well established, change our guidelines and update our prescription.
All right, thank you. Pharm, you might want to check your mic real quick. You're in and out. I don't know if it's just me.
Oh, really?
Your audio was, because I know you're saying some really, really important stuff there, but I had to really strain. So maybe we just double check that. Yeah.
Hope I'm audible now.
Well, it's going in and out, so at least maybe the mic, but yeah, that's fine. Yeah, just double check that. Okay, great. Thank you so much for the contribution. So I would say, so now that we're saying, okay, no antimicrobials, test, go and check it, and people still they have their habits, and they know that it has worked for them. They take flagyl, it works. They do all that, it works. I would like you to suggest the alternatives to antibiotics, just from the very top 5 conditions that you know people take it over the counter for, and what alternatives do we have that will really ease their discomfort in practice, or suggestion, even home therapy or whatever it is. So let's start with diarrhea. If you don't want to take antibiotics, knowing that they'll take it and they'll be fine, like without spending Imodium that is maybe 3 times whatever the flagyl. I mean, what can they do? I'm curious. I'll go with anyone that wants to go first.
Okay, let me go first. So the truth is that most diarrheal illnesses are self-limiting.
Yeah.
In adults, in children, actually in the UK, a student child does not get antibiotics until after 72 hours, and there must be laboratory evidence of infection. That means the child has had a full blood count that shows that white blood cells are elevated or deranged. So I think the first thing to say is ORS or ORT is the most important thing. And it doesn't have to be the kind that we buy in the pharmacy. So substitutes like Gary water, rice water, even just, light ogi or kababa that we eat locally. So anybody who has passed more than 3 loose stools should first start taking that to replace the fluids. And then they can take Imodium, say for 1 or 2 days. And only if it doesn't stop is when they should see a doctor or see a health worker, because not only doctors that can take care of some of these conditions. So I think that's the first thing that we need to improve as a country. But the UK and other places where they prescribe this, they actually did their local studies. I think we need to find out how it works here. So maybe a local study can inform a local policy for us here. But I think you'd agree with me that most diarrhea is self-limiting from food poisoning or food GI upset. So, you ask the patient, what did you eat yesterday? And he says he ate a large bowl of vegetables. And then he stood 3 times before daybreak. But because of something, he thinks somebody is doing him or something interesting like that, and then he starts taking Imodium. For the adults, most adults are fine until they pass to about 10 times. For children, it's a bit trickier. So you really don't want to wait on, if your child is passing through by 4 or 5 times, you should go to a health center. And then also, what are the signs of a diarrhea that's troublesome? So any diarrhea that's associated with vomiting in an adult is most likely one that needs antibiotics. In children, they could still have had too much of sweets or too much of something, but in adults, especially old people, any diarrhea that's associated with vomiting needs antibiotics. So I think recognizing the signs and education on the part of healthcare providers and patients that they don't need to start antibiotics immediately, I think that would help.
Thank you for that, Doc. So any other, Dr. Olufohunsi, do you have any suggestions as to how to maybe cold and flu? augmentin. That's the go-to for that one. So cold, cold and flu, respiratory tract symptoms, like, so they're coughing, they're in pain, it's starting to look greenish, yellowish. It might be viral, it might be bacterial. They're not trying to go to any doctor. Like, what are these alternatives that we want people to, like, steps that we want people to take to prevent them from just taking, say, maybe like augmentin, amoxiclav, that's the go-to for that one.
Okay. I wanted to talk.
Please, you can combine everything.
The diarrhea, because I had a lot of experience. Okay, I had a lot of experience. I know my son, when he was, I didn't know what to do. I brought him to the hospital. Funny enough, I was turned back that I should go to a primary health center. But on my way, I met an older person who asked me what happened. I said, this boy has been stooling and just said, go and buy Ogibaba. It was a miracle medicine. When I got home, this boy had been stooling for like 3 days. I was afraid because it was really, the first dose I gave him, that was the end. The stooling, the temperature, everything just crashed. I said, wow. So I think we can talk more about this to the parents, or educate people about it. Since then, I recommend it to people. Sure, check the stooling, just try it and see whether it will work, and it worked. And recently too, I had food poisoning because I took a piece of meat. I didn't know it wasn't so good, and I was feeling like anything. I thought, what is flagyl in my mind? I said flagyl, but this one doesn't look like flagyl. And the fact that if I start flagyl, I have to take it for 5 days was also another trouble for me, because I know the implication. So I was like, what do I do? Thank God I looked for Imodium, and I got Imodium and I took it. And this other drug, saccharomyces, I can't remember the trade name, but that is the one that normalized the gut GIT flora. Okay. So I took the two
like a probiotic.
Yes, probiotic, and it stopped. So I think it's not all the, though I still I took ciprofloxacin at the end of the day because the thing continued to come, but I had to complete the dose. I think education is because I'm in healthcare line. That was why I could think about that. But I think we should continue to educate the people to go to the hospital, because a lot of things are going on that they don't really know how to handle, and it is what their friends used when they had such that they want to resort to. So if you don't teach them that it is not all that work for this person that will work for you. So you have to go to the hospital so that they can actually know what is wrong with you and be able to treat that appropriately. Now, talking in terms of respiratory infection, taking augmentin. Well, just like the doctor said, there are some infections that are that may not really be as a result. I mean, some cold, the cough or something that may not actually need antibiotics. Like it may just be allergic. It may be as a result of an allergy. I had one recently myself. I bought something in the supermarket, and it had so many things inside. I discovered that I was allergic to a particular thing inside, and I had cough. I was coughing. I was running. I was having. So I looked at it that this one I know is not an infection. So all I just did was to take anti-allergy, and I endured the symptoms of coughing, because I made up my mind, I'm not going to take antibiotics. I think there are a lot of, it's by education, it's by people knowing what they're supposed to do, that do the right thing. It's because I know what it is that made me to stick. A lot of people that have gone for medicine or whatever to treat such. So I believe that if people can be educated, that it's not everything, every cough you have or every running nose, you need antibiotics. So my brother called me, my senior brother called me. I've been having running nose and whatever from this, and I'm coughing. I said, so is it colored? He said, no. What of the sputum? He said, no. I said, just take Piriton and the thing will sleep. And that was all the things. I think we continue to educate and tell people. At the end of the day, it may not necessarily be an infection. It may just be allergy or one thing or the other. I think that's am I correct?
Yes,
So
absolutely.
Okay.
Please find out. Is Ogi? What is Ogi Baba? Is it the same thing as Ogi? Is Ogi Baba the same thing as Ogi?
The brown one, the brown Ogi, not the yellow one.
Okay.
It's the one that contains, what is the active ingredient?
I think that's
Go ahead.
it's what's it called now? What's the English name for Baba? It's not sorghum. It's not millet.
It's a form of wheat, right? Or some
No, I think it's sorghum. I think it's sorghum.
It's sorghum.
Yes, I think it's sorghum.
Yes.
All right.
So, I mean, do you have anything to add to this, Doctor? I mean, from Ndubuisi, yeah.
Yeah, okay. I was going to talk about the respiratory issues, but that's been talked about. So, you might say, I want to flush my system. I don't know if anybody has heard about that.
Oh, yeah.
Is it blood purifier? Or, or they just had unprotected sex and they just want two capsules of Ampiclox or something like that. So let me start with the blood purifier part. First of all, who told you that your blood was dirty? That is what I'll ask them, back then. So all of this misuse of antibiotics also contributes. People just coming in and say, okay, give me 2 capsules of Ampiclox. I want to flush my system so that my system can be clean. Or I just had unprotected sex. Give me 2 capsules of Ampiclox so that I'm not going to take it. So these are also some additions that are not right. So if you had unprotected sex, what I'll just do, I'll counsel you. If there's need for referrals, fine, we're going to refer you. If you feel that your blood is dirty, what made you think in the first place that your blood was dirty? Were there any signs? Were there any symptoms you were having? We'll rather want to talk about that instead of just going ahead to pop into capsules or whatever of Ampiclox or any antibiotic that you have available, ciprofloxacin, etc. So these are some misuses.
So I like, and so pardon me, because I always like to really ask questions, because in reality, this person that has had unprotected sex and is coming to Ampiclox, like, how is he going to change his behavior? Because if you tell him that, oh no, wait, don't take the antibiotic, just wait for signs and symptoms, the person that already knows that it has worked for him or something like that, like, how are you going to change that? Or you're going to tell him to go and do an STD test first after the matter. So what are the corrective actions before the Ampiclox? Or what are the alternatives to Ampiclox that one can give them, right? So maybe use a condom to find safe sex in the first place, so you don't Ampiclox, right? So I get that, but what else? That would go through modification of behavior.
Okay, for modification. Okay, in the first instance, we want to look at the person's lifestyle. This person has been having unprotected sex and probably has had unprotected sex before and used Ampiclox and presumes that it was the Ampiclox that worked for her. All right, so you need to tell these guys, no, not guys, these ladies now in this case, that now this is where you need some level of emotional intelligence. You need to come down to their level to explain to them. So what I would have done is to, before having sex, there are different contraceptive methods if you don't want to take in, all right? Then, but there are some people who we know that they are not on any contraceptive method. They are not using any IUDs or any implants. So in that case, you might want to explore options of what's the name of emergency contraceptives now, levonorgestrel and all that. So educating these people on what an antibiotic does and how it does and how it works, that is very differently from the mechanism of action of medications that could prevent pregnancy. This will contribute to their mindsets being changed. All right. So these people really, they might still be adamant about it. That's the truth. Some people might just say, leave all those ones, just give me this Ampiclox or give me this thing, you know.
So in your practice, the Ampiclox that they're using, you're saying they're using it for more of like termination versus maybe STDs. Is that what you're saying?
They claim that they're using it as a preventive measure, just like
for pregnancy, not STDs.
After having unprotected sex. I'm not even talking about preventing an STD now. I'm talking about preventing a pregnancy. Yeah,
is that what they use Ampiclox for? Really, that's what they think they're using Ampiclox for. That is so interesting. Because I thought that, because the Ampiclox that I see in practice are usually the guys for STD. So you're saying the ladies also think.
Yeah. So it's
right.
Some might come and, okay, we want to use this for preventing pregnancy. Or some might even come and ask for Schweppes. I don't know if you've heard of that. Schweppes, a bottle of Schweppes, bitter lemon. But this is not medication now. You're looking. You're looking.
No, because it's so interesting. Yeah.
So instead of coming to use 2 capsules of Ampiclox after having unprotected sex, why not use something that is established that will work for you? Why not use levonorgestrel? Why not use something that will work after, that's more effective after 24 hours, but the effect wanes down to the 72nd hour? So these are some things that I've experienced in practice. Yeah.
Okay, thank you for sharing that. Do you guys have any other comments, Dr. Orunmuyi and Dr. Olufohunsi, about this matter?
Well, I just want to say that, like the first example I gave of a senior person that had a patent medicine store, if you don't really educate this, what do they call them, commercial workers or whatever, if you don't educate them, if you just turn them back, they're going to people like that to buy their drugs. Because those people, they don't have anything at stake. They just want to sell and go. Like I was there, she was selling 2 capsules of Ampiclox. I said, why? He said, I should not spoil our market. That is what they use to prevent. In that case, it's to prevent infection. They believe the man may be having some infection so that he won't transfer it to them. So that was the reason why they will come and take 2 before it. Then after whatever, they come back for another 2. So I told her that we shouldn't, that this thing is wrong and it will cause problem. But she just said I should not spoil her, and there was nothing I could do because I can't stay with her in her shop throughout the day. So I believe more of education.
Oh, I think we lost.
Have the opportunity of having them around, coming to our shop or around us. We should really don't kill them. In fact, use a very big line. They don't stop using it. When they need that drug to treat any infection, it will never work. And you know, there's cross resistance. If there is resistance to a particular antibiotic, it also crosses to some other groups of antibiotics. So we have to really educate them and let them know that they are doing themselves more of harm than the good they think they are doing. And more importantly, they should stop that their business that they are doing, because at the end of the day, they are destroying their own future. Thank you. That's what I want.
All right, fantastic. So before we round up, I would want you guys to suggest, are there any antibiotics or antimicrobial that you think the manufacturers need to start thinking of making now, based on maybe some infections that are not working, or people are complaining that this thing is no longer working anymore? we're not finding treatment for this thing anymore. It seems like this malaria itself has taken over. I mean, there's sometimes that you have some certain infection that it doesn't seem that, you know, the efficacy is questionable. Is there anything that we need to start inventing from a manufacturing standpoint, pharmaceuticals, or something that we need to bring into this region that maybe already exists outside of the country from a research perspective that we need to start looking into?
Well, I want to say that the researchers, they are not holding their hands up. I'm sure they are aware of all these problems. Maybe they are making efforts to develop antimicrobial that can fight this, especially the resistant strains. So we should just, WHO is working hard, so there are a lot of things they have put together in form of research, this awareness that we are doing and all of them, so that we can combat the problem. So I believe the researchers are working. There are some drugs in the pipeline, even though, you know, it has to go through a lot of clinical trials, and it's not easy to recruit people that will volunteer to make themselves, what do I call it now, that they will use for the clinical trials. So I believe they are working, and our government to have to encourage the researchers, because it takes a lot of, it's very costly to develop any of these drugs. So I believe they're working.
Okay, great. Thank you so much. Dr. Orunmuyi, do you know anything that
we should do more? So look at the ARVs, for example. The way the drugs have evolved in the last 2 decades is now a single-use drug, which is just fantastic, as opposed to 12, 10 pills the first time. And that's showing the kind of attention HIV has received. Now, in this part of the world, febrile illness in the tropics are common. And unfortunately, the diagnosis of a febrile illness has not received as much attention from the researchers as it ought to. So I know there was a research at NIMA, I think that was 2 years just before COVID, where they had this test that could sort of identify the other causes of febrile illnesses. So, you know, the presentation of malaria is similar to typhoid, it's similar to pneumonia, it's similar at the beginning, it's just fever and chills and all that. So I think we need to get big pharma or local pharma to invest in tests, point of care tests or self-diagnostic kits that can sort of quickly diagnose some of these local diseases. And you'll be shocked as to how many fevers are not malaria, how many fevers are not typhoid, how many fevers are not COVID, and how many of them are viral illnesses. Research has also shown that Thalassemias are quite common in Black people. And at the time we were all in school, it was supposed to be a North African condition. But again, there are no tests to diagnose this special hemoglobin types, which are not sickle, which are not, you know, they're just different. And some of these things can cause symptoms that may be treated by lifestyle or special diet. So it will be nice to see more research in that area, more commercialization of that kind of research, because NIMA has done something like that. And in terms of new drugs, well, I don't know if they're new drugs, but the good thing about the resistance is sometimes you go back to an old drug and it works. So, you know, the situation where some drugs are banned in America or no longer in use and are pretty much very useful here, I think it's a blessing for healthcare practice. So I would keep fingers crossed on that. I think we need all the arsenal of new and old drugs, especially from a cost perspective. Most people cannot afford healthcare the way it's practiced in the global West. And instead of trying to force, you know, that into our practice, I think we need to come up with other ways of detecting illness, even seeing patients. Does everybody have to get to teaching hospital? How can we equip the primary healthcare centers to be able to cater to these basic things as they start? And then the more advanced things can be in specialized hospitals So ultimately, strengthening the healthcare system would help us a lot.
Absolutely, thank you for that. So I have, I'm getting questions, I think. So a question came in that someone said, I think patient education enlightenment is the first step to combat the prevalence of antimicrobial resistance in Nigeria. Okay, so that was a comment. So yes, I think we've addressed that, absolutely. And I think that maybe we can all just give our last statements or words of encouragement to the audience. And we're going to also broadcast this live to like our YouTube channels as to what we as doctors can do, what we as pharmacists can do, and what we as patients can do to just help secure our future in case of incasity, like we'll say. I mean, a lot of people say, God forbid, a resistance is not my portion, but if it's not your portion, is it maybe your neighbor's portion? How are you helping your brother, right? So like, how do we help the community to just, help fight the diseases unknown in the future and in the now, actually? So please, your last comments.
Should we say ladies first or elders first?
Okay, thank you very much for the opportunity. I want to say that especially the tropical infection, the malaria we're talking about, we may not have mentioned so much about it, but malaria is a disease that it's very common and it's everywhere. So I want to just advise that if we have malaria, we should put in everything, all the treatments, we should endeavor to take our treatment seriously. We should not allow what has happened to chloroquine to happen to, I believe that just like our doctor just said, the beauty of it is if we can still go back to chloroquine, but let's let this one work for as long as possible. Let us comply with our medication. And I also want to talk about prevention. We should know that prevention is also better than cure. We should learn to work hard to prevent anyone from having infection, because even the resistant strains are transmitting from one person to the other. Even the food we eat, the animal product that we take, the resistant strains can be transmitted through all this. So when we want to cook up, when we want to eat, let's make sure we cook our food very well. Let's wash our hands. Let's make sure that our environment is clean, so that as much as possible, we will not have any infection, we will not get infected. Because if we get to the era where the antibiotics no longer work, it's like the whole world is going to an extinction, because any small infection may kill anybody. So I want to advise that we should take it very serious, that microbial resistance is existing, and we should do all that is possible to prevent us from getting infection or getting all these resistant strains.
Over to Doc.
Okay, so let's start on a jocular note. I hereby warn all patients, and especially mothers of babies, do not ask for antibiotics. Do not ask for antibiotics. Do not ask for antibiotics. Because they come in and they say, this doctor doesn't know what he's doing. He didn't even write antibiotics for them. And unfortunately, many private places, hospitals want to be defensive and make their clients happy. So they just oblige. That's the first one. And the second one is the best healthcare is actually preventive healthcare, where I believe in a world where there's no sickness and we prevent disease. So for infections or conditions that will require antibiotics, personal hygiene goes a long way. Wash your hands, keep your food clean, use clean water. All these practices we take for granted, they actually go a long way in preventing preventing the need for antibiotics. In the hospital as well, simple hand washing between patients can minimize the need to transfer, to move infection from one place to another. So for healthcare workers, we need to start thinking more about reducing the prophylaxis for antibiotics, or the use of antibiotics as prophylaxis, and replacing that with more sterilizing or sterilized practices, cleanliness and all that. And the final word, antibiotics does not, I've heard of people take it for preventing stooling. It doesn't prevent anything. There's nothing prophylactic about antibiotics, really. Only use if symptoms develop. And as much as possible, personal hygiene can prevent many of these infections. So everybody needs to put their hands together, the healthcare workers, the patients, to make sure we let these drugs serve us forever and ever, or as long as possible. Thank you.
Awesome. Thank you so much, Dr. Orunmuyi. And lastly, Pharm Ndubuisi, please, over to you.
All right. So health prevention, I think for the public health approaches, which Dr. and Pharmacist has talked about, preventive measures actually is a cost-saving means. We are in a resource-limited setting. All right. The ability to be able to channel funds for the right things. We talked about research initially. So when we are able to have good preventive measures, we can reduce the costs of health, and that cost can be channeled into other research areas. Like I know that in the area of genomics, for example, it's a field that is rising, it is coming up fast, and just like we talked about, we have funds that have been dedicated to a large extent in tackling HIV. So once that can also be redirected to research, I think it's also going to be of good. It's going to be of good to the general public. Then also, I'm also of the opinion that developing antimicrobials that has reduced dosage frequency will go a long way. Just like we have in the case of HIV, we have cases of medications being used once a day. And we've known that cases of, we have some antibiotics that are taken 3 times a day, or even 4 times a day. Once we have reduced dosage frequency, that will also improve compliance of patients. So in summary, preventive measures, redirecting funds to research to be able to develop this kind of medication will go a long way in helping to reduce all of these issues of antimicrobial resistance. Yeah.
All right. Thank you so much. Thank you so much. And that's it from us, because I'm super conscious of time. I like to be right on time. Thank you so much to our lovely panelists for sharing with us humongous amounts of just information, wealth of knowledge. We plan to do this, a lot of just thought leaders just sharing their journey and their advice at least once every quarter at One Health. Also, we're going to rebroadcast this messages. I'm going to send that to you as well if you do want to share with your network. Thank you so much for joining. Thank you so much. Appreciate it. Hope you've learned something. Hope everyone has learned something today, and we can go home and not ask our pharmacist for antibiotics. I'm saying it personally because I know what I go through. So this is for my benefits in general to, say, okay, go watch the video so you can learn something. Okay, Baba. Have a great weekend, everyone, and take care of yourself. Thank you so much. Bye.
Bye-bye.